Okay, thank you very much, Finn, and thank you for all coming, and standing room only, so I'm delighted. This is like a Madonna concert in which I promise you I won't sing like Madonna, but I'm glad all of you here, and sorry you can't have a seat. First, thank you for this opportunity. And I'm an infectious disease physician at heart, although I do many other things, and I work. If you think London is miserable, come to Dundee. It's even more miserable in terms of weather, but I am the ray of sunshine from Dundee. I have some conflicts of interest to declare, but let's just think, in a sense, where we've come from, the journey that Fleming and others described following the advent of penicillin. This girl makes a miraculous recovery from a facial wound infection, in a sense, and the dramatic recovery that penicillin and subsequent chemotherapy has brought us. And if you look at the intervention that antibiotics have given to healthcare technologies in the last 50 years, I think you'll be hard-pressed to say what other interventions have been so effective in reducing the burden of illness and infections to humanity. But just listen to what penicillin, or what Fleming wrote about penicillin. He said, a time may come when penicillin can be bought by anyone in the shops. And there's also a danger that the ignorant man may easily underdose himself and bring about promotion of resistance. That is the statement in a Nobel lecture in 1945. This slide just articulates his foresight. A report just produced last month from the O'Neill Commission shows about antimicrobials being available without prescription across the world, a huge contributory factor to the occurrence of antimicrobial resistance. We have a growing population in size, but our dosing of antimicrobials remains how we practiced in the 1960s, 1970s, and the 1980s. We failed to understand that if we don't dose adequately, we will promote resistance. So many of the messages that penicillin, that Fleming talked about in terms of use of antimicrobials are there, but we've not listened to many of the things that he talked about. Your wonderful society really articulates the burden. And all of you are here, nurses, doctors, and a range of healthcare professionals dedicated to managing the morbidity and mortality from one of the highest burden illnesses that we see not only in the community, in our long-term care facilities, and in our hospital facilities through surgical site infections and others. But we have an epidemic of chronic venous ulcer and arterial ulcer wound infections, and we have an epidemic of chronic wounds. And many of our staff and our patients demand that they receive antimicrobials in some form to get them better. How do you manage that challenge and that awareness? This wonderful society talks about the problem. The chairman, Finn, just talked about the problem of antimicrobial resistance. And unless we actually do something about it collectively as a society and as a bunch of professionals, I'm sad to say, as I'll show you very shortly, many of the infections that we take for granted will not be able to be treated because the antibiotic pipeline, in a sense, is sluggish or dry in managing this important problem. We know what we want to do. So I'm going to ask you a question. Sorry, it's a little bit blurred. But who believes that writing an antibiotic guideline for wound infections will change practice? Put their hands up. Okay. So, but we continue to write them. And then we put them on an app, which thinks that will sort everything. And that is what I want to address in the next 10 minutes, is how do we bring about that significant change in behavior so the ambition that we have is realized in everyday clinical practice. The burden is huge. This is old people living in long-term care facilities. Across your European healthcare systems, you'll have more or less people like these getting infections and often being prescribed antibiotics. We have surgical site infections contributing to the burden of diseases. And then we have what we're going to hear in the next talk about a particular vulnerable population for which there's a global epidemic, becoming infected, often with chronic ulcers, becoming colonized and subsequently infected with multi-drug resistant pathogens. How do we bring about some solutions to this? I'll give you an even more extreme example of the global spread of very untreatable multi-drug resistant pathogens. These are soldiers from America and the European Union being treated in Iraq and became infected with a multi-drug resistant, verging on untreatable Acinetobacter infection. How did that all come about? Did that come about just by pure magic? That Iraqi soil was full of, for some reason, multi-drug resistant bacteria that they become colonized with? No. They became colonized and subsequently infected with these resistant pathogens is because the range of healthcare interventions that we take as a matter of routine practice were delivered to these people, particularly broad-ranging antimicrobial exposure led to exacerbation, colonization, and subsequent infection with morbidity from this very difficult to treat multi-drug resistant pathogen. I come from Scotland, so I used a Scottish surname, but is this patient not familiar to you? Long-term care facilities, the nurse or the healthcare professional will take a swab, and lo and behold, the swab will show a pathogen. And all of a sudden, it'll be a reflex action for some broad-spectrum antibiotics because that practitioner will sleep a little bit easier at night because I've given the patient something to do, okay? Because I have treated the family, the patients, the nursing staff, the home's expectations that they must receive an antimicrobial. Is this unusual practice in every day? Hands up. Unusual, what I've just said? No, not unusual. Look at the kind of thinking that goes on in these facilities who manage many of the wounds that we talk about. They certainly guide us in our prescribing. They're probably, I don't know if this is a fair thing or unfair thing to say, but they're happier when we prescribe, and at least we know we've done something. So this is a qualitative analysis of prescribing behaviors from a range of healthcare professionals articulating what they feel about intuitively the prescription of antibiotics in this setting. We have a huge problem. As Finn said, up to 50% of all prescribing is either unnecessary or inappropriate. A large amount is done in the community, but we for too long have focused on prescribing primarily in the hospital setting. I call that the sexy setting, is where 20% of all prescribing is happening, but we don't think about community prescribing, and it is not the remit of this presentation to talk about the global prescribing in animals and horticulture and fisheries and so on, which is a subject in its own. So the drivers of resistance are massive, and this slide really thinks about all the things we have to do to try to address resistance. And sometimes you may lose the will to live. And I think that you take this wonderful approach that this paper outlined by Stuart Levy is that you take the grazing approach. You do things in this area, you do things in that area, and you eventually clear the field. So it's not point in time to do everything. Do bits, and collectively there will be a solution that is doable and with the appropriate outcomes. So to me, stewardship is one of the strategies in terms of preserving what we have got so that we have the increased longevity of the wonderful range of antibiotics we've been blessed with over the last 40 to 50 years. So it's about prudent use. And in simplistic terms, it's about what drug to use, how long to use it for. The dosing bit is very important, and can you stop it or de-escalate it to something more narrow is really the driver behind how we can reduce or ameliorate this particular problem. The goal is about improving outcomes. Don't talk to surgeons and physicians about controlling costs. When I talk to them about stewardship, I'm going to help you make your patient's outcome better. I will help you make the safety of managing your patients in your ward or your setting better. Ultimately, what I want to do is reduce the burden of resistance and collateral damage through C. difficile and so on. So how we articulate the goals of stewardship to the particular audience that you're speaking to are very important. And how we do it We love systematic reviews about what works, what doesn't, in what setting. And these are strategies to say that actually, to me, when you're trying to influence the behavior of your children, you stop them by shouting at them, you will not do this. So there's this sort of pre-authorization bit, but the majority of the strategies around supporting, reviewing, and educating at the same time. So these are the kind of two main things that have been very influential and very good in terms of strategies. One is what we call the front end, and the second one is the review post-authorization. And I think how many times, the patient is on a ward, they've had a broad-spectrum antibiotic, and it's an E. coli or Staph aureus that is flucloxacillin or nafcillin sensitive, but they still remain on co-amoxiclav or piptazo, which is the kind of homeopathic medication for surgical use in every practice. You will give that, and they will be very reluctant to change, even though the microbiology, the clinical progress of the patient is telling them otherwise. I think we need to try to influence that process in an effective way. Each of the organizations that you work in, healthcare facilities in the community, as well as secondary care, need a program around stewardship. And I think this is a wonderful opportunity to think about that. You need 6 things. You need leadership and accountability. You need expertise. You need somebody to say, I'm going to do 2 things in the start and then build on those 2 things. You need to be able to track what you've done, measure what you've done, and you need to be able to feed back. And at the same time, it needs to be underpinned by the process of education. That's just the key thing that you need to do. How have we done that? Well, in Scotland, we have tried to do it through leadership. That's important. Okay, so you need a local leader in your organization or local leaders within your organization to help you drive, to get people to do the right thing. We need a very simplistic strategy. This is a UK strategy about starting smart, based on timeliness, based on predicting the models of what you may need to do to start the patients on treatment, but then the focus. That's the review, the microbiology, the clinical progress, the duration. And this resonates with doctors and nurses and pharmacists and other healthcare professionals because it's simple, it's intuitive, what they do the majority of the times in their everyday clinical practice. But we need to be able to measure, because whatever we do, if we don't measure what we're doing, we won't know whether it's improving or it's getting better, and we need to be able to feed that information back to the people who are doing it. And again, in the United Kingdom, and particularly where I work, we've tried to drive measurement to influence people's behavior. Because when you give surgeons or dermatologists or physicians data about their own prescribing, about their own outcomes, that is actually quite a powerful message and a driver for them engaging with you and perhaps changing their behavior. I'll give you a case study, and this kind of hopelessness only occurs in the United States, Ben, so forgive me, but I suspect it'll be familiar to many of you. This is a study showing admissions to hospital for skin and soft tissue infections. Whilst 97% of all the organisms they isolated were gram-positive cocci, familiar to all of you, 80%, up to 80%, received broad-spectrum gram-negative and anti-anaerobic as well as gram-positive cover. So you would agree that is a real requirement for some thinking around stewardship. So they put in a range of interventions which will be familiar to many of you around how we cut down the amount of antibiotics. They did guidelines, but they did education, they did order sets, so they're actually changing the system of care. They collected data, they gave data back, they got champions, leaders. All the things I've talked about in the last 12 minutes, they did to try to influence their prescribing of these very broad spectrum agents for complicated skin and soft tissue infections. And they brought about a reduction in prescribing duration. Did they cause harm? That's what the surgeon or the clinician wants to know. Well, they showed that even by reducing the amount of antibiotic and the type of antibiotic, their patients did not come to harm. Because the only way you will actually engage and influence a clinician to say, by doing what you ask me to do, will I cause harm? And many studies now in the stewardship arena are beginning to look at evidence of harm, as well as benefit. How do you engage? You engage by data that is fed back, hopefully from a peer that they respect, and in repetitive manner. If you don't feed this information back, the change is much harder. In Scotland, we produce some data that we give back to all our clinicians about their prescribing, but we also set targets. So that's the kind of whip end in terms of you've got to meet a target as well as get some data to drive your improvement. And I'll show you on one slide how it works. You get data around your prescribing behavior, about your compliance with policy. It's included for surgical prophylaxis as part of the surgical prophylaxis checklist, which all your surgeons across your hospitals use. This data is then fed back, and every time you walk onto the ward, the patient and the public will know what is your level of compliance. So if you're Mrs. Smith's daughter and you walk into the ward and your prophylaxis compliance is 70 to 60%, you can challenge the healthcare professional team and say, why are you doing so poorly for this particular indicator? So in a sense, it's trying to get a broad level of engagement about how you change practice and behavior. I'm going to finish on wound management. So this is a bunch of indicators that we use at a governmental level for prescribing a range of drugs. And you see, because we live in a very dark northeastern part of Scotland, antidepressants come very high. So we have a major problem with large amounts of antidepressants used for no reason. We have introduced within that, as an indicator, antibiotic prescribing. And over the last few years, the misuse of antimicrobial wound dressings. So every practice, every health board now understands why is your use of antimicrobial wound dressings so high compared to other boards throughout Scotland. It is challenging, and it is bringing about the use, unnecessary use of antimicrobial wounds as an important part of the stewardship agenda within our own healthcare systems. And I think that is something we need to think about collectively. To finish off, we're here to get educated. Is this the most effective way of learning? This is passive me talking with you. This is not the most effective way of bringing about long-term education. You can use delivery systems like apps. We have a MOOC. Don't know if you've heard of a MOOC, a massive open online course, which is now going to be launched in September around stewardship. So you can learn over a 6-week course around all the things that we've been talking about, and I would urge many of you to engage in it if you're interested. We have a very brand new module for nurses to learn about stewardship, and not only about infection control, but I hope we work with you to bring about and tease out some of these educational objectives around stewardship and how it will help a nurse when she or he is practicing in everyday clinical care to how we can use antibiotics better. So I think, ladies and gentlemen, I think I've hopefully communicated to you that resistance is a huge problem. I think stewardship is one important strategy and facet. I think we overuse topical and systemic antibiotics. I think we have to use a range of strategies that engage and change behavior. And I think the role of all of you in this audience as a multi-professional group is key in driving that improved behavior. And I hope that you will come with us on this journey to make that happen and with the two societies. Thank you very much for your attention, and thank you.
Thank you.